The first minute to introduce myself. So I'm Mathieu. I'm working as a statistician in the Global Tuberculosis Program in WHO HQ in Geneva. And I was invited by TB MAC to chair this seminar. So thanks to you for this opportunity. So this is a TB MAC seminar. So the objective is to have a good discussion and a friendly discussion and a constructive discussion between us. So this seminar will be about the impact of COVID. We'll know that COVID had a huge impact on TB diagnosis and TB notification, with almost 18% drop in TB notification in 2020 as compared to 2019. But we have also some concern that this effect also worsen in already existing inequalities, so particularly age and gender-related inequalities. So we will discuss today and have presentation from two separate studies that attempt to evaluate this impact with two different approaches, quantifying the change in TB notification by age and gender. So there will be two studies presented looking at the country-specific notification over time. So the first study will be presented by Finn, and using an approach with linear models, while the second study will present another approach looking at the same trend presented by Jay using time series. So we will have the two presentations from both. So first, Finn, so he's an assistant professor in London School. He's a mathematical modeler with good experience and great experience in modeling infectious disease. So he's also a TB MAC Secretariat Epidemiologist. And Jay is a doctoral candidate at Karolinska Institutet. He's a medical doctor from University College of London and also an infectious disease specialist. Here we have a common previous life with Jay. We worked together in MSF for a long time before. Jay was an advisor for MSF in TB, HIV, and hepatitis, and worked in several countries also. So this seminar will be recorded. I think it's already started, as you have seen. So we will have the two presentations. So we'll have first presentation by Finn, then maybe 5 minutes for questions for clarifications, and then presentation by Jay. And then we will go for a round of discussion and questions. So don't hesitate to use the chat or raise your hand for asking questions. And I think we can just start now in the interest of time.
Brilliant. Thanks, Mathieu. So I will be, as you mentioned, talking about the inequalities and the impact on TB diagnoses by age and sex. And I think what we've done here is a sort of slightly more broader view, and then Jay will kind of dig down in a bit more detail into children in particular. So we all know that there are large inequalities in TB case detection that existed by age and by sex before COVID came along. We know, for example, it's more difficult to get clinical diagnoses or bacteriological confirmation for children, or men have more difficulty accessing care and so on. But we're concerned that COVID-19 associated disruptions might have exacerbated these inequalities. So we know, for example, from areas other than TB, that we saw in the UK, children had a greater reduction in A&E visits during the pandemic, or in the early days of the pandemic. And in Singapore, we saw something similar with clinic attendance for children and older adults. For TB in particular, we knew that in Malawi, women and girls had a greater reduction in TB diagnoses. But then in contrast, in Mozambique, men had a greater reduction in diagnoses. And we knew that in India, more women than men were diagnosed with TB. And obviously, this is quite a big reversal of previous trends. So we wanted to ask the question that, were there any global trends in this for TB? Was the risk higher for any particular age or sex group? And here we focused on TB notifications reported to WHO, as that's what we had available. So we looked at notifications in 45 high burden countries. So we pulled together here the high TB burden countries, TB, HIV, and MDR. And we looked over the period 2013 to 2019. Prior to 2013, so the way that some of these were recorded was slightly different. So this is as far back as we could go. And we looked at, oh, sorry, I should mention there was insufficient data in particular for Angola, Mozambique, Papua New Guinea, and Uganda. So we didn't include them in our analysis. So otherwise it would have been 49 countries. We had these notifications by age. And here we chose to split them into children under 15, adults between 15 and 65, and then the elderly older than 65. And we also had them by sex. And so here this is for men and for women, so who are in both instances older than 15 years old. Because we had a maximum of 7 data points, time was the only predictor that we used to avoid overfitting our models. So we fitted Poisson regression models here using time, and you can see this is expected notifications for a particular country, age group, and sex group. You can see it depends on the variable time there. So what we did was use this to predict the risk of missed or delayed diagnosis due to COVID-19. So we did this by comparing the expected and the actual notifications for 2020. So over here, apologies that there's an x-axis missing. This is time along the bottom here. So you have 2013, 14, 15, and so on for notifications for adults in Azerbaijan, as an example. And then we looked at, we fitted to these data up 2013 to 2019, and then we used that to estimate what the expected number of notifications were, and we compared that to the actual observed number. And that gave us that difference there, that risk of being missed or delayed. And we estimated confidence intervals, or we derived these using normal approximations of the log count scale. So once we had this for each of our individual groups, so for adults and children, for example, we used that to estimate a risk ratio for being missed or delayed. So it looks at the risk of being missed or delayed, which is dependent on the expected value and the observed value. And we look at that for adults, and then we compare what that looks like for children, again, looking at the expected and observed value. When there was an increase in notifications, so I think this has happened a surprising amount of time, for different age and sex groups, there were more notifications than expected. Sorry, I realized I'm moving my mouse on the wrong screen. So sometimes notifications were up here and we saw more than expected. And when that happened, then we assumed that the risk of being missed was 0. And then to avoid numerical issues when we were calculating the risk ratios, we assumed that observed was the same as expected minus 0.5, just to avoid numerical issues there. We used parametric bootstrap sampling to derive confidence intervals. And then once we had this for each of these different, adults compared to children, adults compared to elderly, and so on, then we conducted a random effects meta-analysis across the different countries to see whether there was any trend in these risk ratios. In countries where there was a risk of 0 in both groups, so if there were more children and more adults than expected, for example, then we removed them from the analysis. We decided to define what evidence or what we expected to see beforehand. So we defined there being evidence for an association between age or sex and the risk of being affected by the pandemic. Strong evidence if there was a small p-value and a large effect size, and then some evidence if there was a p-value between 0.01 and 0.05 and a large effect size. And then lastly, if there was a large p-value between 0.05 and 0.1, but the effect size was very large, greater than 25%, then we said there was weak evidence. We considered that weak evidence of an association between age or sex and the risk of being affected. But if the effect size was small or the p-value was very large, then we assumed there was no evidence for an effect there. So in 2020, we estimated that around 200,000 children younger than 15 years had a missed or delayed diagnosis as a result of COVID-19. So compared to how many we expected, an additional 38% had their diagnosis missed or delayed as a result of COVID-19. In adults, this was 1.1 million, 22%. In the elderly, 235,000, 500, or roughly 500,000 women and 860,000 men. So broadly around 20 to as high as 38% in each of these groups had a diagnosis missed or delayed as a result of the pandemic. What we did see also was that we had more notifications than expected in at least one age or sex group in 18 out of 45 countries. So in 18 out of those countries, one group, adults, for example, had more notifications than we expected, which was a surprisingly high number. So I'm going to take you through the results briefly. So this is the risk ratios for adults compared to children. So here we're looking at, did we think children were at an increased risk of being missed or delayed compared to adults? Has that exacerbated that inequality? So if the risk ratio is greater than 1, then the first group was more impacted. So here, if the risk ratio is greater than 1, so these blue ones to the right of 1 here, then that means that children were at an increased risk of having a missed or delayed diagnosis. And you can see we have quite a large number of countries here and 2 regions, the European region and the Eastern Mediterranean region, where children were at an increased risk of being missed or delayed as a result of COVID compared to adults. Overall, 13 countries had some evidence that children had an increased risk, but surprisingly, 10 countries actually had evidence as well that adults were at an increased risk compared to children. I think one of the things that's worth pointing out here is because of the assumption that we made about if the observed notifications were greater than expected, we used expected minus 0.5. And that means that we have some up here, for example, and down here, when we have these numbers are approximately 0 or approximately sort of infinity, it's the result of that, the fact that in this instance, there were more adults than more adult notifications than expected. And down here, there were more child notifications or notifications in children than expected. So overall, though, you can see, even though we have quite a large number of countries where there was some evidence that either children or in some cases adults were at an increased risk, the overall risk ratio globally was not different to 1. If we do the same again for the elderly, so again, if we're looking at blue now, that means the elderly are at an increased risk compared to adults. You see that we have a really large number of countries, 29 countries have some evidence that the elderly were at an increased risk compared to adults. So even though adults may have had notifications, may have had less chance of being diagnosed as a result of COVID, it was worse for the elderly in a large number of countries. However, in a few countries, it was worse for adults between 15 and 65 than it was for the elderly. And as a result of this heterogeneity, we have, again, a risk ratio that isn't, there isn't evidence that the risk ratio is different to 1. And then lastly, if we look at women compared to men, so in this instance, if it's to the right, then that means that women are at an increased risk of having diagnosis missed or delayed. And if it's to the left, then that means men are at an increased risk. You can see that we have around 9 countries have women at an increased risk of having diagnosis missed or delayed. And for men, there's also 9 countries where men are at an increased risk of having diagnosis missed or delayed as a result of COVID. And in addition to that, in the region of the Americas, because there's just Peru and Brazil in these high burden countries, there was also evidence that men were at an increased risk. Again, though, mainly as a result of this high heterogeneity, you see that the risk ratio isn't significantly different to 1. So we did a couple of sensitivity analyses on this. And the first of these was to look at separately high TB, HIV, or high MDR TB burden countries. And what we broadly found was, as you'd expect, that our results were fairly qualitatively similar, just looking at different subset of these countries. However, if we excluded countries where there was no evidence of impact in at least one group, so if instead of looking at countries where some groups had an increase in notifications, we just looked at those where all groups had had a decrease in notifications as a result of the pandemic, we found strong evidence that both children and the elderly were disproportionately affected. And then because we were using a very simple approach here with these Poisson regression models, we also looked at excluding countries where there was poor model fit. Here we define this as a pseudo R-squared less than 0.5, or limited data. So if there were less than 5 data points out of the 7 possible between 2013 and 2019. And if we excluded those countries where we felt there was weaker, less data, or weaker or poorer fit, then we again found strong evidence that the elderly were disproportionately affected and weak evidence that men were affected. Overall, though, we found no evidence globally that the risk ratios were systematically different for any of our groups, for children, adults, the elderly, men or women. There was no global evidence that the risk ratio was systematically different. But I think it's really worth pointing out how high heterogeneity was in this. And part of the issue there is that there are multiple sources of potential confounding here. So things like age structures in different countries, gender roles and responsibilities, non-pharmaceutical interventions for COVID, also the timing of those interventions, whether they happened early or late in the year, healthcare service burden, and barriers to access due to cultural practices and so on, individuals' personal protective measures. And then this just came up in discussion the other day. There's also something we weren't able to control for, which could potentially be important, particularly bearing in mind that a lot of countries had evidence that the elderly were more at risk, is that a confounding factor potentially there is that the elderly excess deaths as a result of COVID-19. So it may be that the elderly with TB were at an increased risk of dying as a result of COVID-19, which could also have affected their whether or not they were diagnosed with TB. So I think that's another confounding factor that we weren't able to address here. But all of that said, I think in the majority of countries and in some regions, we did find evidence that either children and or the elderly were at more risk of having diagnosis missed or delayed as a result of COVID-19 compared to adults. And in fact, in nearly half of our countries, there was evidence that the risk did differ by sex, but it wasn't consistently either men or women that were affected here, but there was a difference there. So I think our main conclusion here was that there was a real need for this context-specific data and evidence-informed action when thinking about catch-up campaigns and so on to achieve equity in TB care, because a number of groups, particularly the elderly, but also to an extent children, potentially had, in many countries, had this inequality in access to TB diagnosis worsen as a result of COVID-19. With that, I'll just end, and with thanks to the Light Consortium that funded this, and to Mark, Rachel, Peter, Rebecca, and Catherine for working on this together. Thank you. Over to Jay.
Thanks, Finn. Any quick question for clarifications before we go to the presentation of Jay? Otherwise, we can keep the other questions more for discussion for at the end of the second presentation.
Mathieu, there's one question in the chat from Nick Menzies. Is that for now or for later?
Oh, I think there could be a quick Nick, you can go hi. Okay, we can have it after.
I was going to say I can answer because that's a sort of a clarification one. It's a missed or delayed diagnosis or reduction in incidence. I think we can say for 2020 that due to the long, slow timescales of TB, that probably most of this is probably reflects missed or delayed diagnoses. But certainly from 2021 onwards, we don't know whether that reflects incidence or diagnosis. For 2020, it probably, I would say, misdiagnoses, but there may also be an element of incidence there. But definitely an interesting discussion point afterwards.
Thanks. No other clarification? Okay, so I think you can go ahead, Jay.
Thanks, Mathieu. So I've given lots of presentations in the past, but I think this is probably the most intimidating crowd I've ever given a presentation to, even if it's online, because I'm a clinician, I'm an infectious diseases specialist, and yeah, this work, I must say, I did quite a lot of the actual modelling, but found very difficult. So we're going to talk about the global impact of COVID-19 on childhood tuberculosis. The group that I work with are predominantly paediatricians. Most of you all know James Seddon and Liz Whittaker in London. And so I guess the angle that we took was more looking at children specifically. This work was published late last year. And again, I think our aim was to try and publish this before the global TB report last year. So Finn's kind of gone through most of this very carefully, but from a pediatric TB perspective, I think the last decade has seen quite a lot of progress. In general, there's been a real increase in the understanding of disease burden, both from reporting from countries and through the WHO, but also through research and better monitoring. There's been increasing adoption of molecular diagnostics, which we know are more effective in younger children. There's been a specific focus on training and education for the detection of TB in children all over the world, and child-friendly drug formulations have improved treatment response and treatment access in many parts of the world. Regardless, though, in 2019, there was still a very high burden of disease in young children, and about 520,000 were diagnosed and notified in national programs from probably an expected number of about 1.2 million. It remains a top 10 killer in children under 5 specifically. So again, Finn kind of went through this, but we know that the pandemic was extremely disruptive for health systems. At least initially, we didn't really know the effect of coronavirus on younger children. And so the public health interventions ultimately impacted children very significantly, both from an immediate perspective, but also probably from a long-term developmental perspective. And mortality from the disease was found to be pretty low. There's multiple reasons that Finn's outlined really well to suspect that the pandemic really damaged TB management in children and in other patient groups. And so in this study, we tried to use global notification data to quantify the effect of coronavirus pandemic on the number of children notified with TB. We were also a little bit interested in seeing if there was any correlation between the level of public health intervention on social movement with the relative change in case notifications. So we used annual case notifications to the WHO from 215 countries from 2014 to 2020. We excluded, I think Finn mentioned 2013 data, but we excluded that because we felt there was poor quality and missingness in some areas that we wanted. We used new and relapse case counts by country, age group, and sex, and we defined 3 age groups that we were interested in. So the 0 to 4 years, 5 to 14 years, and 15 years plus. We used aggregates to calculate WHO regional and global estimates, given that we were including all country estimates. We time series modeled using 2014 to 2019 data to predict 2020 notifications. And we tried to use that as a counterfactual representing an estimate with no effect from the pandemic. And ultimately, we reported predictions by age group, of those 3 age groups, by sex, for the 30 high burden countries from the 2021 WHO definition and by WHO region. So model selection, so we took 216 independence time series, which represents 2014 to 2018 data to fit ARIMA models with a variety of combinations of these PDQ parameters. P represents the number of lagged values, D represents the order of difference in between those values, and Q the number of terms in the moving average. So the 10 combinations with the lowest mean corrected at AIC we used to predict 2019 notification counts as a fitting method. And then the predictive accuracy was measured as the total absolute difference between the predicted and observed values for 2019. Ultimately, in the WHO regional and global estimates were calculated through aggregation, point estimates and variances for the 95% confidence or predictive intervals. And we use linear regression to examine the correlation between the percentage change in 2020 case notifications against government-imposed social mixing restrictions for the 30 high-burden countries that we defined. So coming to our the results, starting with kind of observed 2020 notifications, we saw that between 2014 and 2019, global notifications in the youngest age group, so 0 to 4 years, had increased by 70% in total. So that's the chart on the left there. If you chop off the last year that's predicted, most of that increase was driven by Southeast Asia, as most of you would understand, and India in particular. There was a lesser increase in other age groups, so 38% and 25%, but of course a global increase in notifications. In 2020, from the observed notifications, we saw a decline across all age groups, all regions except for Africa, and the youngest appeared to be most affected. So a reduction of 28% in the youngest children, 21% in older children and adolescents, and then 16% in older adolescents and adults. The decline was more in boys than in girls, so men and women in all age groups. So in the predicted 2020 notifications using the time series modeling, the predicted 2020 notifications are of course more than the observed in all age groups and regions. So they're represented, I can try and show you. So the 2020 observed notifications are the dot at 2020 for each of the different WHO regions represented here, and the predictions include the confidence interval or the predictive interval using this kind of flame display. So the greatest difference between the predicted 2020 notifications and observed were in the youngest patients. So 35% reductions in the youngest children, 28% in older children and young adolescents, and then 19% in older adolescents and adults. In the majority of the 30 high burden countries, we also showed a reduction between the observed and predicted 2020 notifications. So you can see in the red all the high burden countries with a reduction, where the observed were much lower than the predicted, but a handful of countries at the bottom there where actually the observed were greater than the predicted. In the 28 high burden countries where we could actually use their data for the stringency index, there was no association between social restriction and difference in 2020 observed and predicted notifications. So sorry, I've chopped off the x-axis there. I think it comes at the end. Yeah, so mean COVID-19 stringency index on the x-axis, and the y-axis showing change in tuberculosis notifications between 2019 and 2020. So coming on to the sex disparity, so between 2014 and 2019, we saw that amongst the observed notifications, we saw that there were more cases in males than in females in the youngest children and in adults. So the proportion of boys in the age group 0 to 4 was 55%, and the proportion of men who are over 15 was 62%. And then in the age group 5 to 14, I think the sex disparity was less clear, but you can see that across all the years, the ratio was slightly in favor of females compared to males. And also another way to show this, we used we plotted the ratios for all of the 30 high burden countries across all of the years, and then took an average. And what you can see is on the left there, amongst the youngest age groups, the predominance is towards boys rather than girls. In the middle age group of 5 to 14 years, there's a real variety of different different estimates, and I think the ratio we couldn't really, it was very close to 1. And then we know that in adults, there's more men than women. In our observed 2019 versus predicted 2020 data, we showed that there was a similar relative reduction in the youngest children and the adults by sex. So if you see at the top there, around 35% reduction for both sexes, and in the older age group, around 18 or 19% reduction in both sexes. But what you see in 5 to 14-year-olds is that there was a more there was a larger reduction in the case notifications in boys than in girls. So our conclusions were that the reduction in notifications seemed to be greatest in younger children when looking in an aggregated way. The reasons for these findings remain quite unclear to us, but the findings seem to be apparent across a variety of different countries. The sex difference in TB diagnosis is quite well established in adults, but less clear in children and in adolescents. And the access to better age delineated data, I think, helps us to start seeing some of these relationships more clearly. Children, of course, develop disease much quicker after exposure, so could notifications in younger children serve as a measure of transmission during the pandemic, given that we're really unsure about how to use notification data to really show changes in transmission dynamics. And after years of gains in childhood TB management, we kind of, at least our group, feel it's very important to advocate for a dedicated catch-up interventions. So, of course, I didn't do a lot of this work. Well, a lot of this work was done by some of my colleagues, so I must thank all of them for contributing to this manuscript and some of our funders. And yeah, there's the link to the manuscript and the code.
Great. Thanks a lot, Jay. Yeah, thanks a lot, Jay, for the very interesting presentation. Thanks, Finn. It's two very good presentations with a strong analytical part, so that's very good to see. I think we can now open the discussion. So if you have any question, please raise your hand or take the floor or write in the chat.
I saw in the chat that Sandeep was saying some countries like India and Indonesia would have monthly notifications since 2019.
Yeah.
Obviously, some countries have quarterly data available. I guess I wondered, thinking about this as a non-statistician, whether that would be enough for you. So you get something seasonal from 2019 maybe, but then you would also want the sort of longer term trends in notifications over previous years as well. So you could definitely compare 2019 to 2020, but you might not capture those kind of longer term trends. And I didn't know if like this, and Brazil, thanks, Nick. I mean, is there a sensible way to kind of put those together to get a trend, an annual trend from the longer term data and a sort of seasonal trend from just what's available in the last couple of years?
So Pete, while we were doing that analysis, Pete also mentioned this, that there are a few countries that are reporting more frequently than just the one-off. And we parked that to say it was too hard. So we were excited that there is that opportunity, I think, in the future to look back at seasonality as a contributing factor, but thought that kind of combining 1 year of different interruptions or different data reporting was going to be too difficult. Pete, did you want to jump in and mention how you might think about trying to combine those two concepts?
Not especially. So what I mean, to think about some of the more temporally disaggregated data and splitting up. Yeah, I mean, No, I don't have any. I mean, I think it would be interesting to look at, but I don't have an immediate. Yeah, I think it would need thinking through a bit.
Thanks. Nick, you have a question?
Yes, I do. And I'm also trying to, I see David's weighing in at the same time, so I'm trying to digest at the same time. Which is just a comment on that last one about the sort of temporally disaggregated data. I think it is a really interesting route to go down. I mean, it only pertains, as I think the point David's making, to the short time period, immediately after potentially sort of lockdown started, and we can say, okay, that's all due to changes in access to care. That is, in the end, that's a short period of the pandemic, and then after that, it all gets sort of mixed together. But still, if we do use those data, I think it's important to be careful that I think in many systems, the timing of sort of notification can be different from the timing of starting treatment, can be different from the timing of the first diagnostic result, can be different from the timing of when the person sort of attempted to access care. And so just making sure one is using the most appropriate date. And ideally, it is probably the timing of diagnosis rather than the timing of notification is important. And that doesn't really matter if we're dealing with annual data, but if we're moving down to, say, monthly data, that could matter. I was thinking about, so Finn, in your presentation, I was struck by the fact that, there wasn't, as you showed us, a single message across countries, and that that for some countries it looked like there was an increase in notifications, and other countries less. Most of those statistically significant. I wonder if one could take a negative control approach and look at the 2019, just to understand sort of what of this is sort of coming out of, or just, because we shouldn't expect to see differences in 2019. There's only a hint of a pandemic then. And so that might be just one way to check these results. Because I think, to me, it's completely plausible that, different countries responded in different ways. And so it's entirely possible that, we would see different findings. But also a Poisson model does assume that the only source of uncertainty is kind of the coin flipping uncertainty. And then if you get a country like Indonesia or India with huge numbers of notification, that coin flipping uncertainty is very small. So I think that would be one way just to sort of test that.
Yeah, that's a good idea. Thank you. We didn't do that. I mean, the other thing which what you were saying was making me think about was that I don't know offhand how readily information is available apart from prevalence surveys or something which would tell you what inequality there was already existing. And, so it's also plausible that inequalities might be changing in 2019 compared to previous years. Obviously, we would hope not nearly as much as up to 2020, but actually it's a bit difficult because we only really have for a small number of countries where we have prevalence surveys, and even then not for things like children would we know how much those inequalities are already there or sort of worsening over time. Yeah, but that's a really good idea. Thank you. We also had suggested recently that it might be useful or interesting to look at high income countries where perhaps the reporting was better for some of these, in which case, and that's not something we've done either, but I think we can do relatively easily, and to think about how that's changed.
Yeah, noting that in those countries, well, if I think about the high-income country I'm sitting in, the balance of sort of recent transmission to TB cause due to existing disease is going to be different. And so what we might find in, the US or France or, England might not generalize to the settings where we see a lot of TB.
Yeah. Okay, thanks. Just before Mark, there was a question in the chat. Will access to healthcare be an individual factor to consider, given the disruption of health system across countries? I think it's a tough question because it's difficult to measure, I think, but maybe if you have a piece of answer about that.
I mean, I wondered how much that's sort of more for Jay, because you did think a little bit about that stringency, which is kind of presumably linked.
Yeah, yeah. So we used, I can't remember exactly what it, we've got the reference in the manuscript, of course, but we use this Oxford stringency index, which Pete would know more, but I think they took a measure on a level between 0 and 100 for every day that a country reported. So I think we took a mean for each country and then tried to compare that with the reduction in notifications, and couldn't find something that was really strongly associated. Couldn't find a strong association, let's say. But of course, what does the Oxford Stringency Index really mean? You know, there's so many variations and variability in trying to do that we put it. I think we put it in the manuscript, but none of us felt really strongly that this told us something valuable. I think just coming maybe back to Nick and David talking about high-income countries, at least in the country that I officially live in, there's almost no transmission in countries very, very small. So the pandemic essentially meant that TB was almost eradicated because there's no one coming into the country. So yeah, challenging to really think about that as an approach, and definitely for the right-wing government in my country, they were very happy with this.
Thanks, Jay. Mark?
Yeah, thanks. This just really going back to Nick's point about the modeling, and that the PROSA model that we used with Finn. It is an incredibly simple model, and the only uncertainty we really allow for is the coin flipping, as Nick put it. And I like the idea that we could use 2019 to check the validity of the model. The main problem we had with all of this, and it is just the extremely limited data that we had in terms of time points. And so that was why we chose a very simple model with a very simple term for trend in time. We didn't have any data on any sort of confounders or even other covariates that could explain other variation that we see. So we deliberately kept it very simple. We could explore the idea to test for 2019 data. So I like that idea. But in general, I think let's try to keep this as simple as possible. We had started initially with just the linear model. And I said, but actually these are count data, and we should do something a bit more, where the model is a bit more principled for it. But the main problem was, from a modeling point of view, was just the extreme sparsity of the data that we have.
Yeah, I agree. Thanks. And I was thinking about something about that also, and was wondering if you have considered any different shape in time, instead of having just a linear term, maybe having some additional terms or splines or quadratic or this kind of other trend, because we can't imagine that for all countries it's purely linear, and maybe the trend in the years before might be not exactly the same as in the previous year, and then this would capture in the linear, whether it would not have been captured in another trend.
Yeah, that's a good point. So and certainly we've seen for some countries where the model just didn't fit very well, and in the end we just ended up excluding those. Again, as soon as you add parameters to here, especially for the trend over time, it gets very tricky to get anything really meaningful. So that's why we kept it very simple there. We are working on another project now. We look at other other data where for various reasons we can have a bit more flexibility, and clearly there we see much more different shapes. I think here still broadly linear didn't do too badly for most countries, but in other situations you definitely want to explore others, whether that's a quadratic, polynomial things, whether you use splines, whether you use fractional polynomials, that remains to be seen. But again, you probably want to use something that doesn't add too many parameters to estimate.
No, yeah, I agree. It was just a question that came into my mind, and looking at the different trends in the notification over years per countries could be very different. And I agree that we should keep simple. Maybe Pete just raised a question. I think it's linked to the model. Was there a random slope for the years, or in the model too, in addition to the what? Yeah, sorry, go ahead, Pete.
Sorry, it's more just kind of thinking about it's this kind of discussion before around the variation between years that is much larger than you'd expect if you looked at the variance of the mean and thought it was Poisson, and thinking about like the meaning of p-values against a prediction in a country level. And I guess I and maybe I missed it before, but I would be thinking about having like explicit modeling of the variation away from whatever trend there was, and then you basing a p-value off that, because it's definitely larger than 1 over the square root of the mean or whatever.
Yeah, that's probably a good point. Yeah, I mean we didn't do that, so yeah, we just kept this fairly simple model here. And yeah, so obviously when we sort of aggregated results, that was sort of we used sort of random effects there, but not specifically now for sort of modeling the slope. So yeah, that's something we could have considered. So yeah, thanks for that.
Thank you, Mark. I saw Nick, you put a comment in the chat about another neighboring approach. Do you want to say something, or?
Oh, these are just small ideas. This is more so if people didn't like the Poisson assumption, there are other models which don't, essentially there's another parameter in there allowing for some extra variation. And so a negative binomial model could do that, but that's just, I think one could suggest a lot of, small tweaks. And so, important to note that all of these models are simplifications of some sort. And so maybe it's just useful to tie this back to what we're trying to say. I mean, to me, this data shows or the results you show, even with the model you ran, that there is big variation across countries in terms of what happened. And so I think it is important to think about the likelihood, but it's also important to think, well, what are the things that would drive that? Certainly, because it's not sampling uncertainty. I mean, because that's what the Poisson model is allowing for. And so why would we see such big differences across country?
Thanks. Maybe it would be good to go back to the more impact, what would be the impact of such findings, rather than just discussing additional more technical question, which is I found personally very interesting, but maybe to keep some space for what could be some impact of these findings, and I think it's also linked to one of the questions in the chat from Suzanne a bit before, and particularly if we can have some reactions about this, why the youngest and the males apparently are most affected by this reduction in notification, if there is some ideas, and also what kind of other source of bias that also can arise from this model that could explain, I mean, not explain, but at least I mean, have some impact on the findings. So, and also about I think this sex disparities is also an interesting point, and particularly for the younger, the 5 to 14, I think from Jay's presentation, when we saw girls being more susceptible at that in that age group. So if people have some thoughts about that, would be interesting also to discuss this point. Or if you want to add something, Finn or Jay, about that specifically, that you had already thoughts from your paper or anything.
I think for us, Mathieu, is that diagnosing and treating younger children particularly is extremely challenging. It's still kind of a niche area of tuberculosis and childhood disease management in many countries. So we kind of, at least personally, I kind of feel like a lot of this disparity might be due to secondment of a handful of very, very specific staff in some countries. So secondment to other areas of healthcare or disease themselves where they were off work or died. And so, yeah, I think at least in the last decade that I've been working on pediatric TB, there's been a lot of progress. So simplifying models of diagnostics and care and decentralizing and so forth. But ultimately, it comes down to a relatively small workforce to do a lot of that work. And yeah, during a pandemic where particularly kind of staff that were trained in management of respiratory diseases, infection control, they were seconded to other places. We frequently found TB clinics that were closed when I was visiting other countries. So yeah, it wasn't a huge surprise to me to see that there may have been more of an impact on younger children, the diagnosis in younger children, which of course leads to probably greater mortality and other knock-on effects that I think we all kind of know about.
Okay, how do you see then these findings influencing the, potential future catch-up policies for recovering from this decrease in notification in the coming years? We've already seen some recovering in many countries in 2021. It seems to be progressing the same in 2022. I will not spoil you too much. But what kind of impact you can see in terms of policy for future catch-up?
I mean, I would say from our side, so we found these sort of global lack of trends and difference in risk ratios, but I think some of that really was swayed by this sort of a small number of countries where there were more notifications than expected in adults in particular. And so for me, one of the things that really stood out in ours was that in so many countries and in a lot of sensitivity analyses and so on, the elderly were particularly affected here. We only recently were sort of talking about the potential of excess deaths to kind of have made an important difference there. So I haven't thought through if my sort of first response to that still holds, but I feel like that's probably highlighting a need to focus active case finding activities and so on some groups, in particular the elderly and potentially children as well. So, maybe it's suggests that in some settings we should be directing active case finding activities to some particular settings and so on. I mean, for children, I wonder if one of the obvious ones is increasing household contact management or increasing the emphasis on household contact management, where you might expect to see more children having had missed or delayed diagnosis. And in addition, people spending more time at home, so there might be additional household transmission going on. So maybe that sort of might emphasize tools like that in particular. But that's my sort of, I think it looks like really context specific was part of the problem from what we found.
Yeah, thanks for this. Jay, you want to add something or?
Not particularly, but I'm kind of intrigued by, during pandemics, like the effect on health systems and other diseases, let's say. And so in a child who's 1 year old, you kind of think, well, TB is a very, very dangerous disease that needs addressing immediately. And how to communicate that, how to address that issue that the same disease might be affecting communities in different ways, and to try and mitigate against mortality in a 1 year old versus an older person or an adult being able to wait 6 months or 12 months. I think that's extremely challenging. Because at least for me, I think one of our reasons for looking more closely at children was this kind of concept that, yeah, TB disease in a younger child is significantly more dangerous than in older people because of the diversity of disease and so forth. Yeah.
Great. Thanks. Is there any other question from the group? So thanks, Mark, for the clarification in the chat, the technical aspect. No other question. Maybe I might ask one, which is not really a question, but it's more like what's going for the future. Do you have you thought about replicating this work with the 2021 data or upcoming 2022 data, just to see in terms of catch-up. So we do kind of same modeling work, but looking at the catching up of terms of notification, and again, stratification by age and gender to see the increase in notification after this 2020 decrease, and where there is still some gap in recovery for specific age groups and our gender.
So just to say from our side, I think the short answer is we're not looking at that, partly because the funding was sort of short and time specific, but also because I think, as David and Nick pointed out, it gets really complicated with whether you're looking at notifications and incident, or what you're looking at then if you're looking at incidents and notifications and so on. So it's really hard to know what you're seeing actually mean. Is it a good or a bad drop in notifications or something? But I just saw also in the chat that Emily says they're working on a paper with Vietnamese data, which is really interesting, and they have looked at 2021 as well.
Okay, great.
I don't know, Jay, if you're planning more.
I don't think so. Nothing specific at the moment.
Okay. Any last? Yeah. Sorry. Go ahead.
So maybe I can end with, from your perspective, Mathieu, as someone sat at WHO producing the GTB report and so on. Is this sort of thing useful for you and your thinking, or do you look and you think, oh, good, nice, and does it affect thinking at all?
No, I think this question came into my mind when I was reading and looking at your presentation, because I think it was very interesting to look at this and super helpful to understand this drop in notification, looking at these different age groups. And also as a statistician from background, I was also interested in trying to find a way to replicate this work with additional data. But I agree that it's very difficult because 2021 we are mixing lots of things, so it's difficult to understand exactly the patterns of the notification. But I think that would be also interesting in a way to continue to explore this impact, particularly in the younger age group, I think, because this is really where there is still a big gap, and that could definitely be something interesting to look at and to continue to explore, because there are still lots of unknown. And again, from this year, I mean, there are still many countries that didn't really catch up the pre-COVID level, and they are still far behind the pre-COVID level of TB notification. So we still have this problem. So maybe this kind of analysis could be maybe replicated to some of the countries that did not catch up in 2021 yet, or I don't know, some potential ideas in very specific countries or very specific region, because there are so many disparities and so big heterogeneity, even between just the region. So this kind of analysis might be something more specific, yes, to some countries, and that would be something of interest to look at in these countries, particularly big countries where the notification are still far away from the normal level, I would say. Okay, I think we have passed the time by 3 minutes now. So if there are no last question, I just want to thank everyone for joining this meeting. Thanks, Jay and Finn, for the great presentation, and to all for the very good discussion. It was a pleasure for me to chair this meeting, and just like again that if you want to register to the TB MAC newsletter or Twitter, I think Finn, you will share the links to the people so that you can be aware of the last seminar and meetings and everything. Yeah.
Thanks, Mathieu. And maybe just before everyone goes, to also have a plug for Juan Vesca and Kevin Schwartzman, who will be talking next month and I'll send a newsletter out hopefully in the next few weeks on cost and cost effectiveness of scaling up target regimens for TPT in Brazil and South Africa. And also, if you'd be interested in presenting to the TB MAC sort of audience, do let us know, because I think we're always happy to hear from new and different people. And thanks, Mathieu, for chairing.
Thank you. Thanks, everyone. Have a good end of day or wherever you are.
Thanks.
Thanks.
Bye-bye.
Bye-bye.
Bye.
Thanks,
Talk to you soon.
everyone. Bye.
Bye bye. Thank you.